Thank you very much. JJ, what an inspiring talk. My expertise is in building new business models, healthcare economics, and change. And really, no great change can happen unless you have that mindset of abundance and seek the art of the possible. I have a challenge here because with a clinical audience, I'm going to try to make healthcare economics interesting. And I think it's highly relevant because really for two audiences, your patients and clients, it affects them every day. And it affects you as practitioners on how you can actually run and build a practice. Let's see, there. My thesis is very simple. If we believe that an integrative and functional approach can successfully address the root causes of chronic disease, then there are enormous economic opportunities today that we can successfully expand this model. The first part, if you've been attending these, has been discussed in many different ways. So I'm going to really unpack the second part by getting into some of the root causes of why chronic disease is contributing to most of the costs of healthcare. In Davos this year, Dr. Francis Collins, the director of the NIH, said that healthcare only drives 20% of health outcomes. To this room, that's a pretty obvious statement, but it's very interesting that in both the basic science and the health policy community, it's really becoming an underlying accepted fact that you have to understand what's happening with the exposome, how it's affecting genetic expression, how behaviors are doing this, and the socioeconomic impact. What is not clear is when you look at the different clinical and business models out there today, you have to ask yourself how many of the clinical models that are out there are actually dealing with these other root causes of health. So if we take an economic look, let's look at what the U.S. consumer is spending today. This is from the U.S. Bureau of Labor Statistics from last year. And it breaks down spending, and it provides, I think, some very interesting ways on how to think about the root causes of healthcare costs. The biggest spend is on housing, so $18,000 a year. Getting clean air, water, environment is critical. Healthcare spending has now become the second largest item, so $9,000 spent per every man, woman, and child in this country. And over half of the spending is completely invisible to the customer. It's been spent by employers or the government. You can see the consumer health insurance spent once a year. That's what's coming out of pocket that the consumer can see. And the amount that's actually spent out of pocket directly on healthcare is the smallest amount, but it's the most sensitive because the consumer feels there's all this other money that's being spent. Food is obviously a critical input into health, and education affects healthcare decisions. So about 85% of what the consumer spends a year is actually affecting their health outcomes, not just healthcare. This is a pretty complex chart. It's from the Upshot in the New York Times, but it says some very important messages around economics and this country over the last 25 years. The graph shows change in income for each percentile of a household, and you run from households from the lowest 1 percentile to the 99th percentile. The top graph shows what income changes did in the 90s. And pretty much everybody got a lift in income. The concentration in the top 5% and 1% can be seen. But between 2000 and 2014, no income bracket actually got higher income. And what that nets out is over a 25-year period, most of the country has not received a higher income. And if you wonder what's fueling some of the election, that's clearly a picture of what's going on. Now add on to that what's happening with healthcare costs, which is usually going up by 1.5% to 2% of the GDP growth. Rand calculated for the decade of 2000 that if healthcare had just been managed at inflation, every family would have had an extra $5,000 in their pocket. And that would have lifted them up to a positive income. So healthcare is robbing are citizens of a higher income and of a middle-class existence. And my good colleague, Dave Chase, is putting together a movie on this. If you want to follow him at the Big Heist, it's very interesting. He's trying to communicate through film about this whole issue. But it's come to such a limit now that these forces of healthcare economics need to be addressed. So if you look at this graph, this shows what's happened the last 7 years. When we had the Great Recession, households needed to squeeze. So this chart on the left shows that every single item, food at home, housing, transportation, food away from home, clothing, all got squeezed. The only thing that went up was the cost of healthcare. And most of that was in deductibles or in co-insurance. Co-payments went down. So households that are squeezing their budgets, the only piece that's going the reverse direction is healthcare costs. And now if you look at this on a global basis and you ask the question, is healthcare costs getting us better outcomes? This is oftentimes people show the Commonwealth Fund data, but I'm a data geek, admittedly. And Chris Murray, who was the co-author with Julio Frank, the head of health in Mexico in 2000, the initial WHO report, has basically assembled, with the gift of $100 million from Gates Foundation, now the planet's largest database on health. And so you can go to healthdata.org and see all of this. But what this graph shows is actually that if you look at health outcomes, he's consolidated the health span into a single metric called disability adjusted life years. And it basically, as countries get richer, usually they have better health outcomes. Now in this graph, red is bad, it's lower than expected, and blue is better. So Spain and Portugal have better health outcomes. Russia has worse health outcomes compared to their income. And you can see in the U.S., the U.S. really is an outlier on the downside of health outcomes. As you kind of click into this data, you can now see the picture of the overall burden of disease, and you can see that the vast majority of disease burden in this country today is chronic disease. And now when you actually break down the total cost spending, chronic disease represents 86% of total cost spending, spending that you have a solution to. If you break it down from Medicare, which is a part of the payers that I've been working in depth, you can see that the spending increases as the number of conditions go up. So the average spend in Medicare per patient a year is about $9,600. So if you have 0 to 1 conditions, it goes to $2,000 spend a year. 6+ conditions is $32,000 a year. Now this chart is very interesting. It shows on the left-hand side the percentage of the Medicare population and then the percentage of total spending. And then the top two colors, the orange and the yellow, show if you have 6 conditions or 4 to 5 conditions. Basically patients with 3 chronic conditions constitute 74% of Medicare spend. And so that's a small part of the population, but by far generating the highest costs. And that population is pretty consistent year over year in that higher cost spend. So my career has actually been spent, in the intersection of medicine and business and policy. I did my training at the University of Pennsylvania, where there was a community of physicians who were very interested in being impact agents. And when I got out of residency, I tried to think, what was the way that I could have the biggest impact and take the biggest challenge on. And so I went to Baltimore and basically worked in a set of federally qualified community health centers in West Baltimore, same kind of neighborhood if you watch The Wire, and worked there for 5 or 6 years, both seeing patients, but also really doing the business side of operations and finance. And one of the things that I learned in that time with the community health centers is the importance of partnership and collaboration. We got all of the community health centers in Maryland together. We basically got together with Johns Hopkins that was forming a Medicaid health plan, and basically we brought them the patients for the health plan in exchange for equity. 20 years later, I'm on the board of Baltimore Medical System. The equity that the individual community health centers had paid for more uninsured care than the grants that they were getting from the federal government. So really, because the health plan Priority Partners basically is the #1 Medicaid plan now in the state of Maryland. So it taught me that you could really get the business side to work well for very needy sets of the populations. I then spent about a decade at McKinsey & Company, working with some of the largest institutions, both in the U.S. and in the globe, around healthcare, value issues. So for example, with the state of Tennessee, we spent a year with, Governor Bredesen in the mid-2000s, where they faced an issue where Medicaid had constituted such a high percentage of the state budget that 90 cents of every new tax dollar was going to health care and was being taken away from education, from roads, from other infrastructure. And they just had to solve that issue. And so the cost issue is really paramount in this country. And I would tell you that stakeholders are really looking for the right answers, answers that you have today at your fingertips. I also think that on the clinician side, you're looking for the right economic answers too. One is, how do we get our patients and communities to make the right investment in health? Either all that non-healthcare spending to get aligned in the right way. And then importantly, from your practice side, how do you get more resources into your practice so that we can deliver integrative care with the right approach and the right time with patients? So I'll tell you what is not the right answer, and it's just throwing more administrators and management into this. This is a pretty interesting graph that shows that over a 50-year period, you can see the growth of clinicians, which is that red box, and then the yellow is the growth of administrators, which has increased by 3,000% over a 50-year period. And many of these large institutions want to solve this, but they don't know how to solve it. And I believe that the answer really is going to be at the front line, looking at how we as clinicians work with both our patients and the immediate community. And some of the interesting examples, can be seen now in some other best practices. So the picture on the right-hand side is a company called Buurtzorg. They're a group of community nurses in the Netherlands that was founded about 10 years ago. Long story short, they have a model of self-managed teams. They grew from nothing to where they now have 15,000 clinicians, not only in the Netherlands, but in about 30 other countries. And the amount of administrators that they have for 15,000 clinicians is less than 40 people. Because they trust professional integrity, professional judgment, and it really is the modern way of managing professionals at the front line. So what healthcare budget would you rather manage as a clinician? The left-hand side shows the typical fee-for-service spend in primary care for a 65-year-old in Medicare. You could bump it up to $125 a month if you had a direct primary care practice, or if you actually agreed as a physician to try to manage the total Medicare budget, you would have $1,000 a month. So it's an interesting choice. There are, in the last 7 or 8 years, a number of companies that on the traditional side, more conventional side of primary care, have been looking to develop a scalable model that tries to go on the right-hand side of the budget. So a company like Oak Street Health specializes in Medicare Advantage. Landmark takes house calls programs to the sick. Company that I was chief medical officer for, a company called GenCare, took a joint venture with Humana, and we basically scaled it from 0 to 26 centers in 6 states, 18,000 patients in 4 years. And we got that model to work quite well. Just a couple things around Medicare Advantage is now, people don't realize that 31% of Medicare beneficiaries have now gone to this program, which is managed by the health insurance companies. The payers take 15% for administration and profit, but importantly, that Medicare Advantage actually pays for sicker patients. They pay more money. And that's actually been a breakthrough in technology, because in the 90s, there was this competition to attract healthy patients. The risk adjustment is now, that I can tell you as a practicing physician in there, that it's, you get paid enough to take care of the sickest patients. And so many payers are now paying physician groups the entire medical budget. The clinical and economic opportunity has been pretty simple in these models. It's dramatically increased the investment upfront in frontline care, primary care, health coaching, home-based care. There's not been a company yet that has scaled out a functional approach to this, but I think the opportunity is there. Take a 21st century delivery model of taking technology, professional development, and a redesigned care model, and then we can achieve the quadruple aim. We can lower costs by basically the lower downstream costs, pay for the higher upstream costs. We can get tremendous patient satisfaction, clinician joy, and quality. Just to give a sense of the upstream and the downstream economics, this is data from Oregon where the legislature made the payers sort of lay out how much was being spent on primary care. And the average was about 5%. It ranged from 3 to 13%. But if you take the average, you could triple the amount that is spent on primary care if you could reduce the overall cost of care by 10%. Let me give you the results that I was able to achieve with GenCare over the past few years. And this is data that Humana shared with the Georgia legislature of the JV, but it basically is an indexed graph of total clinical costs, everything all in for the entire joint venture. And we had a 40% decrease in admission days. Total cost basically for that budget went down by about $2,000 per person, which per year, which more than paid for the higher investment in primary care. So really, 4 takeaways. Chronic disease drives most healthcare costs, and in particular, patients with multiple chronic disease are driving the costs. I didn't spend a lot of time on this because of the time, but it's really important to know that secondary prevention at this point is a more implementable clinical business model than primary prevention. Risk adjustment does work, so in value-based and capitated models, clinicians have the potential to get paid more for sicker patients, and that there are models right now that are out there that are scaling across the country that have been able to get this to work. So in conclusion, if we believe that an integrative and functional approach can work to address the root cause of chronic disease, there really are enormous economic opportunities to expand our model in the next decade to come. Thank you very much.